Good afternoon, everyone, and welcome to today's webinar. We're going to be talking about evidence-based interventions today, but before we begin, I have a few housekeeping items to run through with you. The first is for those who may not be hearing it, you should now be hearing the audio broadcast, and we are recording this event. If you need any assistance with audio or other technical issues, please type in the All Questions box located at the lower right-hand corner of your screen, and I'll be happy to assist you. I do want to let you know that whether you are listening via phone or computer today, you are going to be muted, but we'll give you lots of opportunities to interact with us through the chat box, and we'll take a look at those in just a few more minutes. As I just said, we do want you to put any technical support questions you have in the All Questions box. If you have any questions for our presenter today, you're also going to put those in the All Questions box. It is literally for all of your questions. Please do not put questions in the chat box, because if you do put them in the chat box, then we can't triage them and respond to them reliably. They usually get kind of lost in the hubbub. So again, all questions go in the All Questions box, and your chit chat goes in the chat box. I do want to let you know that participant comments you do see in that chat box don't reflect the views or policies of the presenters, the Substance Abuse and Mental Health Services Administration, or the Department of Health and Human Services. Your opinions are your own, and the opinions of your fellow attendees are theirs as well. And our final reminder before we get started, this training is supported by the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the U.S. Department of Health and Human Services, or DHHS. The contents of this presentation, much like those comments in the chat box, do not necessarily reflect the views or policies of SAMHSA or HHS, and this training should not be considered a substitute for individualized client care and treatment decisions. That's all of our housekeeping for today. My name is Kristen. I'm going to be here behind the scenes supporting you, but now I'm going to turn it over to today's moderator, Tanisha Burley. Tanisha, I'm going to open your phone line, and could you get your camera turned on for me, please, so we can see you?
Thank you, Kristen, and good afternoon, everyone.
You're welcome. Oh, and you know what, Tanisha, I'm going to stop you for just 1 second. Okay. I forgot to ask folks to do one thing for me. If you all are seeing Tanisha's smiling face, would you please raise your hand to let me know you see her? You're going to do that by clicking the raise hand button at the top of your screen. It looks like a guy with his hand up in the air. And I see, okay, awesome. It looks like folks are finding that. They're seeing you, Tanisha, and they're ready for you to go. So everyone, you can click that little guy again. It's going to put your hand down, and now Tanisha is going to take it away. Thank you.
Thank you, Kristen. I am so looking forward to this webinar. We've been planning it for some time with the anticipation that you all will get some really great outcomes and information. Today's webinar is about EBIs and DEBIs for YMSM, and the title is Hidden Figures. And I'm going to let our presenter go deeper into the content of this presentation today. But I will say that we've had the pleasure of working with our presenter on a number of other projects, and he's been fantastic. His name is Rashaan Gilmore. And Rashaan Gilmore is a community connector, organizer, and collaborator. He is particularly passionate about making a difference in the LGBTQ community of color. His current project is Blackout, a newly formed organization which seeks to organize and mobilize the Black gay community in Kansas City and develop a leadership core. Previously, he managed multiple significantly sized SAMHSA and CDC-funded grants for an FQHC. So with that, please let me turn it over to Rashaan. Well, go ahead. So Rashaan, please turn your camera on. Thank you.
You should be sharing, or you're seeing me now?
Yes, I can see you well, clearly.
Okay, fantastic. Thank you so much for that warm introduction, Tanisha, and I'm really glad that each of you is taking time to be a part of this presentation today. I have one primary expectation, and I know that you guys have several, and we're going to talk about those, but my principal expectation is that I'm able to deliver to you practical strategies that will help you make improvements to your programs to reach the target demographic that you're after and to make sure that we are having a true impact in the communities that we're serving. So thank you so much for being here, and we'll jump right in. So I titled this presentation, this webinar, Hidden Figures, and a critical intervention for prevention programs struggling to overcome challenges of reach and efficacy with EBIs and DEBIs among the most at-risk and difficult-to-reach populations. And it seems to be that for a majority of these programs, folks are struggling to find the participants that they're looking for, and we're going to talk today about how to do just that. First, however, I do want to go over sort of the background and description of this webinar, and to let you know that our description of it just basically includes the fact that we want to enhance your knowledge of how to reach this demographic and to make sure that you're provided with all the tools you'll need to leave this webinar and immediately begin implementation of some of those strategies. One of the key objectives that I'd like to focus your attention on is that we really want to focus on barriers to program recruitment. I know there was an early sort of poll or survey of registrants to find out what were some of the core areas that you were most looking to learn about, and recruitment was one of them, but we're also going to talk about engagement and retention as well. And then in terms of outcomes, one of the goals that I think you will all agree is super important is that we're going to look at what's working well in other communities. And so I have a good example today that I think will answer some of the questions that are out there in terms of what's innovative, what adaptations can be made, what new strategies can we employ to sort of get things moving in the right direction. So if at any point you have questions, as already has been mentioned, just drop those in the all questions box, and Tanisha will jump in and whenever it's appropriate and ask those questions, and I'll do my best to provide succinct and thorough information. So why don't we talk about what one takeaway would you like to make from this webinar today? Like what one thing would really make this stand out for you? So go ahead and feel free to jump in with your feedback, and we'll hear from you.
And for those of you who may be unfamiliar with the Adobe Connect interface, I just want to make sure everyone sees the chat box. It's in the lower left-hand corner of your screen. It's labeled Public Chat, and you may see some orange text from me in there. I'm going to bump the bottom of it up just a little bit because I know sometimes folks have a hard time seeing where to type. But all you need to do is just type in that little white box at the bottom of the chat area and hit enter. And it will send us your comments, and we are really looking forward to hearing about what you are hoping to get out of today's webinar. I see Fran is typing. Let's see, who else wants to be brave and jump in? We're not going to unmute your line and make you talk or anything like that. We just want to know what stands out to you. And if you run out of time, we can always come back to this as well. So Rashaan, let's wait and see what Fran has to say. And then we'll leave this question in the chat box for folks to respond to as they feel moved, and we'll keep going after we hear from Fran.
Great.
Great. Oh, so Fran's really interested in strategies for implementing evidence-based intervention for young men who have sex with men. And I know that that's something you're going to get into in some pretty good detail here, Rashaan. So do you want to take it away, and we'll keep an eye on these chat comments?
Sure, and I think to sort of jump into that, we have to understand why young men who have sex with men is really an important audience for us to be trying to reach, and to look at the global picture, if you will. In the United States, we know right now that the CDC estimates that 1.2 million people are living with HIV, and one in eight of those don't even know that they're infected. And every year, 44,073 new cases of infection of HIV are reported. 81% of those occur in men, and 67% of those new cases are in men who have sex with men, and a full 3% of those are with injection drug users. What's perhaps most alarming is that adolescent MSM, ages 13 to 24, have a 22% increase in incidence. So we're seeing the numbers growing and in the wrong direction. And so that's why we're totally focused on this right now. But let's break down why we have this focus on black MSM as opposed to just MSM overall. And the first thing you need to know, if you don't already, is that black MSM are the only subgroup with an increasing HIV incidence. And there are a lot of reasons for that, prevalence in communities of color for one, but also because when general health issues are ignored as part of the overall health of black men who have sex with men, one of the things that happens is that we focus solely on STIs and HIV, and that problematizes and further stigmatizes black men who have sex with men. Another thing is that we often focus on deficits and pathology instead of actually looking at the assets and resilience of this tremendous group of men. A third, and I think is critical one, is that intersectionality of race and sexual orientation are not often addressed. So programs that address black men's health often leave out any sexual diversity. And on the other hand, programs that talk a lot or address LGBT health initiatives often ignore racial diversity. And so that intersection is often left with few resources, and we're somewhere lost in the middle. And among African Americans, they have the highest lifetime risk of HIV diagnosis. But I want to draw your attention to something really interesting here. Of the 44,073 new HIV diagnoses in the U.S., 44% of those are African Americans, 26% of them African American women, 22% of them youth ages 13 to 24. But if you look at the chart on this on your screen right now, you'll notice that it says that African American men have a 1 in 20 chance of becoming, or a lifetime risk of becoming HIV positive. 1 in 20. If you look at the numbers for other groups, take white men, where that number is substantially lower, 1 in 132, that really says a lot about where we are right now. But the news gets a little bit more grim before we talk about how we make a change. And if you look now, you notice that black MSM are more likely to have an HIV positive diagnosis. And the CDC currently projects that at current rates of transmission, if nothing changes, if we don't do anything else today, then 1 in 2 black MSM will be receiving an HIV diagnosis in their lifetime. 1 in 2, that's half. And just for perspective, let me just say that there are not population centers anywhere in the entire world with a 50% HIV diagnosis rate. And in fact, going a step further, if we were to take all black MSM and put us on a separate island out in the ocean somewhere, we would have the highest, according to these projections, we would have the highest HIV diagnosis rates anywhere in the world. That's why this webinar today is important and why the work that we're all doing is so crucial, because we have to find a way to intercept and change these numbers. Otherwise, things are going to get a lot worse before they get better. But we're going to talk about strategies to make those improvements, but I just want everybody to have a really clear picture of where we stand. A couple of other things to really point out. Black MSM are less likely to have health insurance, and there are a number of reasons for that. We can talk about that. They're less likely to adhere to treatment plans, antiretroviral therapy, and they're less likely to be virally suppressed. And there are a combination of factors that are involved here. You know, one of the things I experienced when I first got into this field several years ago, and it hasn't been all that long for me, although we've made some really great progress here in Kansas City, one of the things that was sort of galling for me was sort of the attitude of clinicians and case managers and others when they would talk about black men who have sex with men, that, well, they should just want to do better. They should just want to get tested. They should just want to know their HIV status. But my contention coming in the door was always, when you have to worry about keeping a roof over your head, or if you can keep your cell phone on because that's the only way you can communicate with the world, or if you don't know how you're going to eat tonight or what you're going to eat, it's really hard to focus on trying to take care of your health. It's no different than a school kid who's sitting in the classroom, and of course you go to school, you should want to learn. The teacher expects you to be ready and prepared, and you should be there to give your best. But if you've got an empty stomach and your stomach is growling, it's going to be very hard to focus and concentrate. Well, there's no difference here with black MSM in a lot of instances. So we really have to sort of reshape our mindsets about where this population is and why they are where they are. And that is the step that I think is the most crucial to take to begin turning things around a little bit. So obviously this webinar today is about EBIs and DEBIs that are most popular among MSM. Obviously, I'm not going to be able to provide a whole list of them. There are over probably 100 different interventions for MSM and other groups, but these are the most popular. There will be some on this next slide that you will not see, but these are the ones that I have seen most often used, not only in my community, but in others as I travel around the country. And I'll just rattle them off the list real quickly, and then we'll jump into some of them on an individual basis. So one is social network testing strategies with CTR, counseling, testing, and referral. The other is CLEAR. Another is D-UP, Defend Yourself. Many Men, Many Voices. Some of you may refer to it as 3MV. Also PCC, Personalized Cognitive Counseling. And lastly, Empowerment. So those are probably the 5 most common DEBIs that I see utilized in communities trying to reach Black MSM. And I will say that, of course, you know, the CDC, SAMHSA, the focus has always been on how do we create behavioral change on a level that sort of diffuses it throughout these communities. And I think to some extent there's been some large success with some of these, and we'll talk about where that success lies, and in others probably where that hasn't worked out as smoothly and why. Kristen, is this your chat or mine?
It's mine, and I'm just over here talking on mute.
No, that's
Sorry,
okay.
guys.
I want to make sure. I want to step on your toes.
Yeah, no, it's good. I got my announcer voice on and everything. So jumping off of that, we want to know what EBIs and DEBIs you're using in your program or in a program that's in your area. So what evidence-based interventions are in your program or in your area? And you can go ahead and type in the chat box and let us know. We want to make sure that we know what you guys are doing. And while you're typing there, Rashaan, I want to make sure you know that Kofi Short commented about interest in hearing about good ideas to help with retention of program participants as well in response to that first question we asked. So really the recruitment and retention pieces are huge. So I know you want to make a note of that. And let's see, okay, empowerment, 3MV. We've got lots of comments coming in, and I'm going to go ahead and type this question into the chat box for those who prefer to read the question. What EBIs and DEBIs are you using in your program, or do you see being used in your area? All right, it looks like empowerment is a big one. There's 3 different people who've mentioned that. And we see some social networking strategies. This is great. Risk reduction. Okay, awesome. I see several people are typing, so let's give them about maybe 15 more seconds, Rashaan, and I'm going to make this a little bigger so you can read the responses while people are continuing to type, and then we can move on when you're ready. And y'all can keep typing as long as you like. It doesn't go away.
And it does look like I see that Carol mentioned Community Promise. I'm very familiar with Community Promise. Also Respect. I think a number of programs have begun to phase Respect out. Some may still be implementing risk reduction. So I would say that among the ones that we're going to cover today, 3MV, hey Justin, that we'll definitely be touching base on some of the ones that are the most common among programs trying to reach Black MSM. Okay, and I'm going to ask Kristen, can you bring up the slides a little bit bigger on my screen for me, Kristen? Thank you. Okay, so let's try to jump in. We're going to talk about 3 interventions, and I know that several of you are curious about adaptations, but I want to talk to you about the fact that adaptations, I think sometimes we feel like they have to happen on a cultural basis, and very often that is true. that is absolutely necessary. But I don't think that we always have to do cultural adaptations as much as we have to make some adaptations or adjustments to the fidelity of the program. In other words, how those programs are implemented. And the three that I'm going to talk to you about today, I have had on an individual basis with each of these to go back to my program officers, whether with SAMHSA or with CDC, and say we need to make some adjustments to make this fit and work for our community here in Kansas City. And I've also had clients like in Seattle who had to do the same thing with their GPOs as well, to say, hey, this is not working for us. Can we make these tweaks? So there's a way to maintain fidelity to these interventions because we know they've been tested, we know that they work, but to do that in such a way that allows us to accommodate for local level factors that may not have been a consideration in the development of these EBIs and DEBIs. So the first is D-Up, Defend Yourself, and I think several people mentioned that they were utilizing D-Up right now. D-Up, just to give the view from 30,000 feet, is an intervention that was designed for black men who have sex with men. It's a cultural adaptation of POL, and it's designed to promote social norms of condom use and assist black MSM to recognize and handle risks related to racial and sexual bias. D-Up used to be a 2 or 3 day training provided by Effective Interventions, but I think now it's purely online. So if you're interested in learning more, you can certainly go to their website and do that. It's a community level intervention, the goal being to have impact across a community, and there are 4 sessions. So while we're talking about adaptations, one of the first adaptations that I asked our program officer to allow us to make when we were doing D-Up was to not have 4 sessions. Trying to get people to come in on 4 different occasions, even though you may offer the incentive of a gas card or you may offer the incentive of food at a meeting, that is often too much for folks to come on 4 separate occasions. And as we'll discover later, our demographic often has a lot of other barriers to try to overcome to even get to coming to a session on 4 times. So what we did was I did it in 2 sessions. So sessions 1 of D-Up and session 2 of D-Up I did in 1 day. And then the very following Saturday, I did session 3 and 4. Now some of you may be asking, well, how does that work? Because with D-Up, you have to actually go into a nightclub space and observe the population, look for the folks who are the popular opinion leaders, and then identify these individuals and try to recruit them back. Well, let me pause and say one of the problems that I have experienced with D-Up is that it is built around a model that works primarily for white MSM. And what I mean is, as a cultural adaptation of popular opinion leaders, POL, that you see there in the description, it was based on this notion that you go into the bars or nightclubs, you surveil, observe who the popular folks are, and you say, oh, there's Marvin over there, and Marvin seems to be the sort of the center of the room. Everybody knows Marvin. You said hi or hello. Everybody's come to speak with him or buy him a drink. I need to recruit Marvin. And in general, that works great. But a lot of communities, like my own, we don't have any black-specific or black-owned clubs, nightclubs, or venues. So then what do you do? If you can't do that first step of going to observe and surveil and recruit from the bar or nightclub. So that's already one issue that D-Up never took into account. Now, if you are in a community where you do have that, then you're off to a lot better start than some of us who don't have that. So one of the things that we did was, and you'll see this later on one of the slides, is we created what I called an events-based platform. So by engaging my youth advisory board, and I will tell you, I gave them absolute and complete ownership of this grant and of this program. I tried to make it my business to say no as little as possible and to try to empower their solutions and ideas as much as possible. That buy-in is what got them coming back week after week after week, not just for the intervention, but also for planning meetings around the intervention and other program elements. So their ownership meant that they were steering the bus. So by doing D-Up in 2 sessions instead of 4, by changing how we did our incentives, our guys didn't care about gas cards in some cases. If they didn't need them, what they did was they pooled them together, and we spent more money on food so they could have better food than just having some, sandwiches and chips from Jimmy John's, and they would get some fancy stuff, but they had pooled their money together to do that. And of course, we did have to get our program officer approval on 2 levels, one for program efficacy purposes, but also for the purpose of budgeting. So those were just a couple of quick ones, and we're going to jump into some other ones, but that was what we did with DEBI. And I also have to say with DEBI, a source of frustration that often arose for many of my clients, many of my friends in the community that were taking DEBI, was that it is exclusively condom-focused. Now, while we did not seek to change any aspect of that, I often focus more on HIV 101, which is in the first session of DEBI. And outside of DEBI, I always talk to my guys about risk reduction, harm reduction, and other elements that they can utilize to protect themselves. It's my personal belief, again, not SAMHSA's, but my personal belief that if you give people only two options and they find the other option untenable, well, then what they're going to do is whatever they want or nothing at all, and that's not where we want people to be. The second is CLEAR, and some of you may be implementing CLEAR with CTCR. So CLEAR is Choosing Life Empowerment Action and Results. CLEAR is an evidence-based intervention, and it promotes health promotion intervention that for males and females ages 16 and older living with HIV. CLEAR is client-centered, is delivered on a one-on-one basis using cognitive behavioral techniques, including goal setting, to change behavior. The intervention provides clients with the skills necessary to be able to make healthy choices for their lives. CLEAR is a 3 to 5 day, I think it's now 5-day training that is available, and it's an individual level intervention with 5 sessions. And most CLEAR programs are offering incentives anywhere from $75 to $150 as far as I'm aware. And I know that's what we've done here, and I've seen that in multiple other places. CLEAR is now also being used not only with newly diagnosed positives, but also now with high-risk negatives as a preventative measure. So I like to think of it as almost like PCC, personalized cognitive counseling, but on a much higher level. CLEAR is effective, I think, for getting folks who are newly diagnosed to understand what that diagnosis means for their lives, to begin thinking about how they address stigma from family, friends, and community, and also to do some goal setting around personal issues, and that may include disclosure to spouses, partners, or to family. And in some cases, primary care physicians who are not HIV primary care physicians. I have 2 clients who to this day have never told their doctors that they're HIV positive. So CLEAR is definitely a program that definitely will help with that. One thing I will say about CLEAR is that there's not always a lot of room for adaptation of CLEAR. And unfortunately, when we look at these EBIs and DEBIs, most of them are several years old, and they don't really follow modern developments around technology and things that I think could make the interventions a little bit stronger. So what we've done in a number of cases is to make some small adjustments. I wouldn't even call them cultural adaptations that have allowed us to make CLEAR something a little bit more interesting to our community. And we're going to take a deep dive into it in just a little while. But that is one where some opportunity does exist, but there's not a whole lot of wiggle room when we talk about adaptations. And then thirdly, SNS, social networking strategies. I saw that a couple of folks were implementing SNS. It is an evidence-based supported approach to recruiting high-risk people. SNS is based on the underlying principle that people in the same social network tend to have the same social behaviors and same sexual behaviors and risk factors as a result of that. And so in addition, people in the same social network know and trust each other. So basically, if one person is doing it, I can influence the others to do it, theoretically at least 2. And so for those of you who are implementing SNS with CTR, they usually identify clients or peers who are HIV positive or at high risk for HIV and enlist them to become short-term recruiters. There's a 2-day training for SNS, and I will say if there's an opportunity for you to take the SNS training, especially if it's in your own city or community, or if you're in a position to request it, especially if you can work with your own health departments, local or state, do it. There's a lot of the framework of SNS that I think is of benefit to any other approaches or interventions that you might be implementing. So SNS is a community-level intervention, and it is ongoing. So the way SNS works is you recruit one individual who maybe is positive or is a high-risk negative, and that person is motivated to go out and recruit their friends to test because they'll get maybe $5 to test, and then the individual who referred them will get $5 to test, and so on and so forth, and it matriculates out into the community. SNS can be highly effective, but one of the first things that I did upon implementing SNS in my community was to make sure that we changed those incentives. You can't get people to do anything for $5 these days. You can't even buy a value meal for $5 anymore. So we changed the incentives and we made it a contest. So we did offer a $5 or $10 incentive to the person testing, but for the recruiter, we held all of their incentives and we pooled them together. So it was a winner-take-all competition. And the person who had the most testers, that recruiter won the entire pot of cash. And there was such a spirit of competition among our guys to get folks tested that we ended up testing over 100 people in a 30-day period just through SNS. That didn't include our walk-ins at the clinic. It didn't include referrals from other sources. It was just from SNS. And I think the final pot ended up being somewhere close to $500 for our recruiters. And so we broke it up into a couple of different levels. I think one was $300, another $200, and one was maybe a $150 gift card. So there's an idea when it comes to SNS that might work for some of you in terms of your implementation. So common issues, struggles, and challenges. I think this is the meat and potatoes of where we want to be. And as we go into this, I want you to think about it with this one thing in mind. You have to give the client what they want, not what you want them to have. And I think that is one of the challenges that we often run into when we think about this important work that we do. There's urgency, there's a sense of immediacy, there's a sense of passion behind why we're doing this work. We definitely want to make a difference. We want the lives of our clients to be improved. But the challenge sometimes is that we are in a mode where we're forcing something onto them rather than thinking innovatively and creatively and understanding what motivates them to want to do better. Despite our thoughts about why they should or shouldn't do something, we have to understand what is going to motivate them. And then when we can give them that, we stand always a much better chance of securing their engagement and retention in these programs. So type in the chat box if you would and share some of your common issues, struggles, and challenges that you're encountering or that you see with individuals that you serve. I really want to know, if you wouldn't mind, just jump in there and say, I'm dealing with this or I'm dealing with that, and let's see where we are. Maybe we can address some of those things specifically while we have this time together.
All right, I see we've got some folks typing, so let's give them a few seconds to get those to pop up. I have a question for you while we let folks type. What do you think is the number one most common barrier? And I'm curious I'm asking you because I want to know if the participants agree with you on the number one most common barrier.
I think the number one most common barrier is associated with number one most common challenge, which is probably around recruitment. The barrier, I think, is that for Black MSM, and I speak as one, I think that we are focused on our lives and our health. It does not become the first thing that we think of. That is a barrier from the client side. From the provider side, from the program side, I think the biggest barrier is in trying to find and identify the target audience or target population that we're after. And it's very fragmented, and figuring out how to work your way in there. And I'm going to talk about that some here in just a little bit.
Thank you.
And
I'm curious
to hear if mentioned
if
retention, so that's a big one.
Mm-hmm.
I'm sorry, Kristen, go right ahead.
Yeah. Oh, that's okay. I was just curious to hear if anyone had a different opinion. I mean, the question we originally asked was, what are some of the common issues and challenges you see? It's a little quiet, and I'm wondering if it's because we sort of already talked about these a little bit earlier when we asked people what they want to get out of this, because we did see some of those needs there. So it looks like Kofi and Wendell are both typing. I'm going to be quiet so they have a chance to think.
Participant lines muted.
Yeah, I see Kofi mentioned that, you know, in Milwaukee, their young men are often facing other issues in their lives. And let me just say for a brief moment that it can be challenging sometimes when, particularly if you are a Black MSM and you work in the same community, it can be very hard to separate out, you know, your life from your work. Because we are in and a part of these communities that we're trying to reach to. And that's both a benefit but also a challenge in many respects. But it does help us understand that they have so much else going on in their lives. Wendell, the challenge of targeting both African American and Latino MSM using the same methods. Yeah, you know, I will be very honest with you, and unfortunately I won't have an opportunity to delve too much into the current work I'm doing with Blackout in Kansas City and how we're using a community needs assessment to make some of that work happen. But I think it is very dangerous to try to lump Black MSM, Black trans, and or Latino into the same groups. We try that. I see it tried often. I think there's a danger in that because there are different cultural barriers that have to be addressed and in different ways. I think if you have an opportunity to move into a community and to build a relationship there, you go for it. But trying to burrow in and use the exact same interventions in the exact same way, I think is highly problematic and usually not very effective, unfortunately. Good question, Anastasio, in terms of working with the Asian community and how big stigma is there. Stigma is big in all minority communities, to be quite honest. It's big in general, and not just in minority communities, the mainstream communities as well. I think one of the things that is most important is to find the outliers and begin working with them. The people who sort of just, you know, have the I don't give a D attitude, because for those people, they're willing to take stigma and bias head on, and often you will find that they will have the most creative ideas for how to reach into a community that they are part of. And if you find those people, if you encounter those people, you definitely want to build a relationship with them because they'll have the best ideas on how you do that. Okay, so let's move on a little bit. Now that we've seen what some of the common barriers are and what some of the struggles and challenges are that you guys are having, and hopefully we'll begin to address those through some of what we're going to talk about next. So there are no unicorns. You know, everybody's like, oh, I can't find this mythical Black gay man in my city. I don't see them. Where are they? Well, we're not unicorns. We are there. We're not hidden figures. But the problem is we maybe not offering the things that are most important to attract our attention, and so therefore you don't see us showing up for your programs. But we're in your communities and churches and schools and clinics and athletic clubs and restaurants, shopping malls. We're on the block. We're at church. You know, we're everywhere you guys are too. But what we want from you is a deeper level of engagement that is meaningful, that is authentic, and impactful in our lives and communities. So earlier, somebody mentioned that they struggle with retention. One of the ways that I've been able to overcome that challenge is that I have asked this community to think outside of themselves. I've asked this community to come together in a way that lets us create a vision of how we want to improve our lives and our community. And because they've been a part of that community-wide vision process, they've taken such ownership of it that I don't have to cajole them into coming together for a meeting. I don't have to struggle with whether or not they're going to really follow through on things that they've committed to. They own the process. And I think the more you can give your communities ownership, the better. Now, having said that, I know that as a CBO or ASO or medical provider, you are responsible to a whole host of backers and funders who are anticipating that you're going to do things a certain way. You've got your CDC, you've got your organization, you've got your board. I get all of that. But we have to give as much control to the community as possible. And that, for me, has been the most important way to ensure that we get the kind of attention and retention that we want. So when you begin to engage your community in a broader vision that goes beyond just how do we get people to show up for D-Up, or how do we get people to help us meet our grant deliverables, because, newsflash, the community doesn't care about your grant deliverables. They don't care about your numbers. They don't care. What they care about is, one, how will you help me improve my life in ways that are important to me? And that may mean that HIV care or attention may be a secondary or tertiary concern for me. And two, how will you make this community better overall? That's where your clients are. Understanding, too, that there are a lot of intersecting disparities. And to Wendell's point earlier, you know, people are living these lives where we expect them to focus on just HIV, but they're looking at things like poverty and education and unemployment and access to care, mental health issues, crime rates, incarceration, alcohol and substance use. And those are all on top of other issues that many MSM, particularly from the majority community and mainstream LGBT communities, don't always have to deal with. And so when you live at these intersections, it becomes very, very difficult to be able to sort of navigate your life in such a way that you can live in this bifurcated sort of reality where all those problems over there, but I'm just focusing on HIV over here. And so the more that you can help your clients address disparities, the more likely you are going to be a resource to them and more likely they are going to feel at least somewhat, I don't want to use the word beholden, but they're going to feel a sense of obligation and maybe even duty, and that's not a bad thing, to want to show up for you as well. Because you know what, Rashaan, you helped me get into care or maybe get a prep appointment when I couldn't. You helped me with my resume when nobody else did or could or would, and I didn't know where to go. Or you helped me by pointing me to legal aid services. And I think for folks who are in prevention, I know we've got some prevention and treatment folk here, prevention folk, sometimes we end up having to sort of eschew those areas and let somebody else deal with it, whether it's community health workers or case managers. But particularly for those of you who are in the community and operating from the community side of it, then I think what you really want to make sure of is that you are looking at how you can be a resource beyond just your program or intervention. That makes you useful to them in other ways, and when you become a resource to them, they will, I guarantee you, become just a resource for you too in the sense of showing up for these programs. Among the structural barriers that I really want to highlight are access to health care. It is staggering to me that 19% of blacks in this country still do not have health care insurance. And so when you don't have health care, you're not engaging in your own medical care, and you perceive it to be too high cost, the benefits too low, I'll wait till I go to the ER. We all know this, but think about how that has a ripple effect across other aspects of their lives and how it's like I won't deal with it because I don't have the resources for it. So going back to what I said previously, I don't care if it's around healthcare or another issue. The more you can help address those other issues, those other disparities or social determinants, the more likely they are to be willing to partner with you in exchange. Incarceration rates are higher for black MSM, we know this, and sadly, when we think about testing, only 20 states at this time do testing for all their inmates, and only 3 states offer testing upon release, so that doesn't help. There's low access to condoms, so when we think about incidence and prevalence, here's a big factor right here. And of course, third, stigma. Homophobia and disclosure of sexual identity and HIV stigma are huge factors in why black MSM not only don't test, but why they don't want to be a part of certain, I shouldn't say why they don't test, why we're not where we want to be in terms of testing. Many do test, but also why we're not seeing the levels of engagement and retention in these interventions because of the stigma associated with it. So one of the things that I've often done is I don't do any of my programs at the clinic where I used to work, the FQHC, because if you do them there, sometimes it became a thing where, oh, that's the HIV clinic. I don't want to even be seen going in there. People will think I have something. So we used all sorts of creative spaces outside of the 4 walls. We even did one once in the park, and it made all the difference in terms of people's willingness to come and engage. Personal barriers to HIV and STI testing. And so where I have STI testing or HIV testing, think also in terms of program recruitment, retention, or barriers to being involved in these interventions. Housing, transportation, education, discrimination based on race, gender, or sexual orientation, and that may be happening in some of your clinics and organizations, to be brutally honest. Mental health, substance use, and healthcare mistrust. Now, we usually are talking about with these interventions a younger population, but you might be surprised how many have strong medical mistrust right now. I was talking to a 25-year-old young man the other day who didn't want to go into a hospital for some treatment that he needed because, and he said this, I don't want them to skeevy me. He used it as if it were a verb because he knew about the Tuskegee experiments with syphilis on black men. Oprah Winfrey recently did the HBO special about Henrietta Lacks, talking about how Johns Hopkins Hospital unfortunately took the unique DNA of a single black woman and used that as the backbone for much of our modern medicine. And so that medical mistrust is a factor even with younger people too. So the more you can explain it to them, the more you can guide them the process, the more likely they are to engage with their health care in a truly meaningful way. Someone mentioned earlier about assessing which EBI or DEBI is the right one or the right fit for them. And so let's talk about some things we should look at in terms of DEBI or EBI selection and what you need to do if you need to approach your program officers to say, hey, we may have chosen this in the grant, but we really think we need to look at our logic model a little bit differently and get to a different outcome here. And Tanisha, feel free to jump in with any of the chat comments if that's something that I should speak to. Otherwise, I'll just probably keep going here. Understand, number one, what you're really trying to accomplish. So look beyond your grant deliverables. And what I mean by that is look at community impact and community change beyond just what you have in your grant around what you're going to do with the intervention. It's so important to look at how we can pull folks in and be really, really certain about how they're engaging with these programs. Number two, choose the right EBI and DEBI for your community, not just for your organization or for your grant. It doesn't look like many of you guys are utilizing CLEAR, and that's fine. It may not be appropriate for your community. Knowing that is important. Same thing may be for SNS. There may be a variety of factors on the local level as to why people are not using it. And if that is the case, you just want to make sure that you know that. Third thing, map community relationships to determine who potential partners are. When I talk about partners in this respect, I'm not talking about organizational partners. It's not enough just to say, well, in the grant we wrote that we got a partnership with so-and-so, we got a letter of support, and we're going to refer some folks over. I'm talking about community partners who have that interest, who have that relationship and that credibility. Those are the ones that you want to go to, those individuals. Fourth, assess organizational readiness. When I say, is my organization on board for the long haul, I mean this. One of the things that really upsets communities, especially marginalized communities, if you will, is that organizations will come to us and say, hey, we want to partner with you. We got this great new program. But in 4 or 5 years when that program is over, you guys dispense with us. And so there's a great degree of frustration because we were useful to you as long as you could get your grant numbers, but now that you don't have that grant anymore, you don't care about us. So you've got to be prepared to be in a community relationship for the long haul and to fill those gaps in time between when you do have funding to do outreach or programming in those areas and when you don't. And also, in terms of your organization, it's really important to make sure that if your organization is going to target YMSM, given some of the other barriers that we talked about, especially medical mistrust, that if they're going to be coming into the door of your organization, that your organization is not going to be treating them in a way that causes them not to feel welcome in that environment and never walk through the door again. So that's really important too. So really understanding where your organization is and if they're really ready for the long haul. Assessing technological readiness, you know, I put it this way, are you prepared to use the same technology as your clients? How are you using social media? And if you're using it just to broadcast, you're doing it wrong. If you're using it to say, oh, well, we put a thing up on Facebook and created an event and, you know, if we build it, they will come, that's not how you do it. You do it by being social. And if you're not being social on social media, then you're not going to do a very good job of recruiting folks into your programs. And the last thing is don't bite off more than you can chew. Don't promise the world to yourselves, your board, your grantees, your grant maker, or to your community. Know what you're going for and be able to commit to that.
Rashaan, thank you for that and the overview of how to deal with community and government, et cetera, as you do your work. And we've got a great question here from Timothy Gwynn. What is a good example of how you have engaged the community to relinquish majority control to them while being under government funding?
I think the case study that we're going to look at may address some of that, but I would say that for me it has always been to make sure that I'm communicating two ways. So one is with the community and one is with my program officer, and really keeping them engaged and knowledgeable and aware about what we have going on and how it's working. So when it comes to trying to give community the ownership that it needs, and I think that I'm understanding the question correctly. If I'm not, feel free to jump in, Tanisha. But the way I'm understanding that question, for me, it was really about saying anything that the community wants that was within reason, that we felt like could tie to our deliverables, we would try to make that happen. And that was always my main focus. So I always saw myself in my role as that of an advocate for the community and not an employee of my organization exclusively trying to go one way with it. Does that help? Or, and I'll let Timothy jump back in.
I think that's a good response. And while he's responding, how do you also deal with your funders as a community advocate and also as a grantee? How do you relate to your funders as far as really communicating for your community and then also falling within the requirements? I know there's a delicate balance.
Exactly. It is a very delicate balance. It's tough. I will tell you, I have a simple belief. I don't believe in practicing what you preach. I think that's too high a standard for any of us to bear. But I do believe in preaching what you practice. So I'm not going to tell you some pie-in-the-sky ideal about how you make that happen. I will tell you what I did that worked for me and what I have taught to other communities. And that is to make sure that I engage my funders one-on-one. And I really build relationships with funders. I let them know that while I'm eager to have your funding, it's more important to me to have your relationship because I'm an advocate for this community because I'm of this community and I live this every day. It's not even optional for me. So whether that's true for you individually or personally or not, it's important to make sure that you give your funders an opportunity to engage with the community as much as possible. They don't have that. And I'm not talking about dog and pony shows. I'm talking about real opportunities to engage, to ask questions, for that to go both ways. And when you're able to do that, I have found that a lot of times it opens the funder's understanding of how things should work. So whether that funder representative is the program officer from CDC or SAMHSA, or if that individual is a direct funder from a foundation or corporation, the more you're able to do that, the more they have an understanding. And I took small successes. And every time we had a small success that was based on something new or unique or maybe even a little bit scary sometimes. One example is we did a ball. If any of you are familiar with the ball scene, you know that balls start pretty late. And my CEO couldn't understand for the life of us why she had to let us have a building from midnight to 7 o'clock in the morning. But I was able to advocate for that. We had a great success. We tested some 78 or 100 some people in that night. We had 3 new positive reactive diagnoses. And once I had that success, I was able to go back and say, look what we did. If you keep trusting us, we'll do more of that. And eventually, I could pretty much go and ask for anything within reason, and it was granted. So sorry for that long-winded answer, but I wanted to make sure I tried to address that.
That is a great answer. I really think that relationship building is key so that everyone has at least, even if it's a surface understanding of each other, from everybody's different perspective is so important. So thank you for that.
And it really is about making sure that everybody wants to be a partner. And I understand that not everybody's going to have that. I understand that all communities don't have funders who want to be that engaged or CEOs that want to be that engaged. But you have to find your partners, and you really do have to build. Otherwise, it becomes very challenging to get to a place where you're creating community impact over a sustainable period for any sort of long haul. So let's jump in to look at what we've been doing here in Kansas City. And I understand I'll sort of stipulate up front that I know that this won't work for everybody everywhere, but I really do think that there's some aspects of this that will work for many of you. So in Kansas City, the CDC grant that I ran was called Project I Am. And it was part of the PS 11-11-13. Some of you probably had that grant too. It was a 5-year renewable grant, 5-year grant that was renewed for those of you who went for 17-17-04. And it's one of those situations where we had a number of goals, and among them, 2 core requirements. So one of them was to establish a youth advisory board, and I will tell you, when I arrived at the clinic, it was 2 years into this 5-year grant. It was floundering on every metric you can think of, and the youth advisory board, I used to say defunct, but my vice president would say, no, it was just dead. But we had to sustain the youth advisory board, and also implement programming with the following. And many of you, this will look familiar: collaboration with health departments and your local YNY planning councils, enhanced HIV testing, HIV positive individuals had to be a focal point, high-risk negatives had to be a focal point, structured condom distribution had to be a big part of that, and coordinated referral network was a key to that as well. Project IAM began in 2011 and ended in 2016, although the CDC did extend it from September of 2016 to March of the current year. So, and this is old data, and that will come to another point that I want to talk about a little bit later, but there approximately were 1,200 young black men of sex with men that are at risk in the Kansas City metropolitan area, which is a huge bi-state metro area. I know people don't think of Kansas City as being a big city, but I promise you we have running water and electricity. There's no tumbleweed and covered wagons. It's a very cosmopolitan city, split over 2 states with a total metropolitan population of a couple of million people. And black folks make up about 12% of that population, and 46% of new HIV infections. And what we found in 2009 in Kansas City was that for the first time, the number of new infections among black MSM exceeded white MSM of every age range. And that was a really staggering thing for us to find. So the interventions that we did with Project IAM were D-UP for high-risk negatives, CRCS with CLEAR for HIV positive individuals, HIV testing with PCC. PCC, for those of you who may not know, is really an individual intervention that's basically like a 30 to 45-minute survey, and it's really good for folks who are repeat testers. We all have those folks who, oh, had another scare, had another scare, had another scare. At some point, it's not that you had a scare, you're just not choosing a different behavioral pattern. And so PCC asks questions to help them sort of stimulate that prefrontal cortex of the brain and maybe make different choices around their sexual health. Linkage to care was part of that, and structured condom distribution. So our deliverables: 600 HIV tests, a 4% HIV positivity rate, 150 PCC, 18 CLEAR, and 14 D-UP. And as I said, when I got to the clinic in year 2 of this grant and I took it over as project manager, we were nowhere close to those numbers, not by a long shot. We were somewhat comforted by the fact that other cities like Fort Lauderdale and other places, even as remote as maybe Boise, who had the same grant, they weren't reaching them either. But I don't like to fail at anything I do unless I'm going to get a really great lesson out of it. But I was sure that we could do something different and better. And so what we did was we just flipped this whole entire thing on its head. It wasn't completely revolutionary in the sense of doing something so dramatic and unique that we knew that CDC or SAMHSA would balk at it, but it was in terms of how we approached our community programming. So let's jump into that. The challenges that we had was a lack of community buy-in, and you guys can tell me if any of this sounds familiar, lack of community buy-in, fragmentation among our primary demographic. They were scattered all over the place. There weren't any venues to just show up and say, oh, Thursdays at 5, there are all the black gay folks. There were systemic issues around cultural competency, tied with medical mistrust, the wrong staff, and not to besmirch any of my colleagues or predecessors, stigma, and program attrition and lack of completion with these programs. So I'm imagining that some of that probably sounds very, very familiar to some of you. Feel free to raise your hands if that's true for you.
Yeah, and as a reminder, that raise hand button is at the top of the screen, so you can just click that little guy with his hand up in the air and tell us if any of those challenges seem familiar. And I see some hands flying up here.
Not surprised on that one.
Yeah, I know, right? So we've got four or five hands. Every time I say a number, it grows. So let's give them a second. So if those challenges, I'm going to back that slide up. If these look familiar to you, click on that hand raise button and let us know. And yeah, it looks like pretty much all the hands are going up here. So I think we're on the right track.
Well, I can tell you that, you know, these are common, so you're not alone. You're in the same boat with a lot of folks, but there are ways to address it. And let me say this, too. I am not trying to sit in the seat of an expert and tell you that everything that I have done has been the right thing or the best thing or everything's worked out flawlessly or smoothly. But I can tell you that we have had a great degree of success because at every turn I've made my partners, the community, And so it wasn't that I didn't do something well or something didn't work out great. It's that we just found a new way, collectively working together, to do things differently. Okay? So one of the programs that we did was CLEAR. I mentioned that earlier. And CLEAR, again, is 5 individual sessions, one-on-one. It's sort of a cognitive intervention, working through goal settings. There's issues of disclosure that people work through and that sort of thing. Well, 5 individual sessions. Our grant deliverable was 18 per year. We had only gotten to half that in the prior 2 years, so that wasn't good, and CDC wasn't particularly thrilled about that, and neither were we as an organization or a community. So one of the things that I did coming into this work was try to approach things differently. So I don't have a background in mental health or medical stuff or HIV. I just have a strong interest in working with my community. And so what happened was I was given a brochure day one when I showed up, in addition to a bag of demonstrators under my desk. That was interesting. But I got a brochure, and I'm going to tell you exactly what it said verbatim. But first, the graphic. On this brochure, this trifold brochure that my organization had been using for years, was a graffiti-like drawing of a young black man or Latino man, person of color, with his hat sort of cocked to the side and his pants sagging and a glittery buckling belt, and he's wearing a tank top, and he had a young lady with him, and her breasts were enlarged, and it's almost a caricature, really. And she's sort of leaning up against him, and the copy, the actual text on this brochure read, and I quote, "Don't get caught slipping in your pimping." And I looked at that and said, who in the hell, who am I going to give this to? Like, I would never hand this brochure out. And so I said, there's just no way I will ever do this. And I was so alarmed that it had been in use and that nobody had caught it or thought it was problematic over that period of time. So I immediately threw them all out. And I'm not talking in hyperbole. I got them all, took them to the dumpster, and threw them out. And when I was asked why, I had to do a mini session on why it was problematic. So I said, you know what? I'm willing to bet, I was crazy enough to think this, I'm willing to bet that we can get young men from our own city who would do a couple of things, and we can create our own brochures. One, they would be willing to publicly disclose that they are gay men or bisexual men, men who have sex with men. Two, that they are HIV positive, and that was the real kicker. And 3, that they would be part of a sustained campaign using their images to help promote these messages. And when I said this, jaws dropped across the conference room because nobody could believe that here in the conservative Midwest, if we're not the buckle of the Bible Belt, we're certainly one of the buttonholes on the buckle, that folks would be willing to do that. So what happened is that I came up with this program, this idea called Visual Aids, Positive Images of Positive Men. But we used CLEAR, one of our interventions, as a cornerstone of that program. So let's jump into that. So one of the things that Visual Aids was really about was aimed at reducing stigma. It was associated with people who are HIV positive, taking a bold stand publicly and using their stories and their messages and their images to combat stigma in the community. Positive Images used 10 HIV-positive young men from Project I Am, from my Youth Advisory Board, to start a discussion around what an image could do to confront stigma and promote or prompt a viewer to think about what HIV/AIDS means in the current social environment. So we got famed photographer and HIV activist Dwayne Kramer to come to Kansas City and shoot images of our guys and create an exhibition that drew some 400-plus people to an art gallery during First Fridays in Kansas City, and we have a huge arts district and tons of galleries and restaurants. And any First Friday of the month, even in the cold months, you'll see thousands of people sort of gallery hopping, and we had so many hundreds of people come in that day. But what I said to our guys was, if you want to be a part of this exhibition to help create change, I didn't sell them on taking CLEAR because nobody wanted to. I didn't sell them on incentives because that was not going to be enough to make that happen. I didn't sell them on, hey, do it for the organization or help me out. I asked them if they would be willing to be a part of a bigger vision to create change in our community. And to the person, because my theory was if I asked 10 guys, I would get 5 to say yes and 2 to follow through. Well, much to my surprise, I asked 10 and I got 10, and they all followed through with all 5 sessions of CLEAR. And for the first time in the 3-year history of Project I Am, we met our grant deliverable because those 10 guys signed up to take CLEAR. And before participants were allowed, because some of you may be asking, oh my God, like that could be traumatic for somebody. What are you doing to prepare them for bias? As part of going through CLEAR, I told each of the guys that my CLEAR coordinator had to tell me that they were confident that individuals were ready to make that step. And if they were ready, I would allow them in. I wanted to make sure that there were no unresolved issues relative to their positive status or public disclosure. And so we spent a lot of times in groups with the guys and with a personal narrator who helped them to tell their stories in their own voice, and that was also part of the exhibition. And this is important. We changed the incentive structure completely. I mentioned earlier that most CLEAR programs have an incentive of $75 to $150 for completing the 5 sessions. We chose not to rely so heavily on gift cards. It's always a common thing. Instead, the incentive was you get to be a part of something big, but 1, you get a photo shoot with a renowned photographer. 2, you'll get professional styling, wardrobe, hair, and makeup. 3, you get the opportunity to be a part of a citywide campaign. And 4, an exhibit where they can invite their friends and family, whoever comprises the support system, but most importantly, a chance to make a difference. That was incentive enough. That was incentive enough for our guys. And I will tell you, the gallery space was donated. Dwayne came and didn't charge us a dime. We took care of his lodging, of course. The wardrobe, makeup, and hair was all donated by folks in the community, and it became a real community program. And the results, I think, were really quite staggering. So this is the main group image of the visual aids guys. And this was in June of 2014. And so now every year we have our visual aids anniversary, and the guys all get together. And one of the things they talked about this year, now that Project I Am is no more and Blackout is sort of its replacement, is that they're making visual aids and positive images an ongoing annual program, and positive images a support group for young Black MSMs. A lot of the support groups that we have right now tend to draw older Black MSM, and so younger men don't always feel comfortable, and frankly the older men don't always feel comfortable either. So now we're moving into that space. And I'd like to show some other images from the campaign. Dwayne just did an awesome job capturing these men. All of them under 29, I might add, with the exception of one I think had just turned 30, but all under 29, all from Kansas City, all from Project I Am.
Awesome. Thanks, Rashaan. So following those pictures, what word or words spring to mind? How would you describe those images? Fran said creative, energizing, and totally positive. Kimberly's reacting beautiful. Brendolyn says strong. I thought they were just, they're magnetic. The men in these photos are just magnetic. I loved that. I see brave, healthy, yes. Yep. Wonderful.
I think that's interesting feedback too, the healthy part of it. It sort of flew in the face of what still many in our communities think of as someone who is HIV positive. Empowering, real, uniting. Awesome. Well, I will say that for our guys, it was absolutely empowering. But I will tell you that there was one of the young men, and I'm going to flash back to his picture and tell his story. On the left there, that's my good friend Terrence, a.k.a. Rambo. And he had done a good deal of work with me and speaking at group homes and juvenile centers and that sort of thing. And one particular day, he was out in the community visiting some friends, and a young lady who had been at this particular group home ran up to him so excited. She said, Mr. Rambo, you came to my classroom and you showed us your picture and you told us your story. Oh my goodness, that's so amazing. And so he lit up like a Christmas tree and gave her a big hug. And that was the beautiful part of it. The sad part of it, though, was that the girl's mother, because she had excitedly gone home however many days before that and told her mother about this experience. And so the mother, seeing them from the doorway and overhearing her daughter say, "Get away from that boy before you catch that stuff." There's still work to be done. And so I was so concerned about Rambo when he called me and relayed this story. And I said, "Okay, Terrence, tell me what happened. And how'd you feel about it?" He said, "You know what? That's the first time in my life where I really didn't care what somebody else thought, because I knew I had changed that little girl's life just by showing my picture and telling my story." That, to me, is how you begin to create community change. I know that there's no way possible, given the time that we have and the structure around this, that we can do as much justice to each of the interventions. But I did just want to share that as an opportunity to look at how we took one intervention and really pushed it to the background. We made it less about the intervention than we did about what they got out of it in terms of their lives. One of the things I always say is, if the carrot is big enough, the stick don't matter. If the carrot is big enough, the stick don't matter. So 5 sessions that I would have had to pull teeth to get people to show up for and follow through on. I don't know, I lost my connection.
Me too. It's coming back.
Okay, I thought I lost everybody, or if they just lost me, I'm not sure.
Yep.
No, we can still hear you.
Okay.
Here you are.
Sorry
Now
about that, folks.
Yep. And we're back on the same slide, and that's a good opportunity for me to tell you we have about 20 minutes left, and I think we're doing great on time, but I just want to give you that 20-minute warning.
Thank you so much. And I will just say, I forgot where I was, but that's okay. I'm going to stop doing as much talking. I think that brings us to about, and we did that. Oh, success strategies. You might want those before we go. I am so sorry. So success strategies. Please trust me on this. Please trust me on this. Promote a vision of change, not the intervention. They don't care about your intervention. They care about their community and their lives. And if you start from that point and build out, you'll have much greater success, I assure you. Use an events-based platform if you're having trouble getting people to show or to just walk into your clinics or programs, or if you don't have spaces where you can go and you know you can find them, use events that will draw them out. And that means talking to people in the community who are either doing that kind of work as private promoters, and you can tie into their events, or if you have a youth advisory board and they have ideas, that's a good place to start. It does not take a lot of money to do a really great event. It just takes creativity. One of the things that we did was we started a dodgeball league. People loved it. We have water balloon fights, and people just show up, and we do them just sort of on a humbug, but once you get people there and you're engaging, you got them. Another is genuinely empower your youth or community advisory boards. In fact, my community advisory board for Blackout changed their name. They said, we are not an advisory board. We are a community action board. We're here to get things done. Networking and leveraging partnerships, I think, is so key, and that kind of ties in with this last one. Stay on trend, a term from the fashion industry, by attending conferences specific to Black MSM. One reason why I say that is because you're going to hear from people who are doing the same thing that you're trying to do, or at least they are folks that are trying to come up with innovative ideas and approaches, and that sort of idea sharing back and forth can be so very useful. A few key takeaways: think relational, not transactional. Think relational, not transactional. I'm going to say it again. Think relational, not transactional. If your mindset is, they're going to come get a test, I'm going to give them $10, then you've already lost. But if you think in terms of relationship and really building a rapport, that's where you're going to see the secret to the secret sauce. Okay? At one point, my CEO called me in the office and she said, Rashaan, what's the secret to the secret sauce? And I said to her, Sherry, there's no secret to the secret sauce. I'm just building relationships with folks in my community that I care about and not just asking them to do something that I want them to do. Traditional incentives are not enough anymore. So waving your $5 gas card, the community's over that, and some have gotten quite skillful at collecting your $5 gas card, and this other program's $5 gas card, and this other program's $5 gas card. That's not enough anymore. So quit thinking that dangling those in front of the community is going to be enough to draw them out. They don't care. Okay, so you have to change your incentive structures. Additionally, I'm not saying any of this is going to be easy, but I'm saying it's worth it. It's not going to be easy because you're talking about a demographic that has a lot of challenges. I hate to refer to them as just a demographic because I'm a part of that, but there are a lot of challenges to overcome. And so you had better start seeing them in a different light so that you understand where they're coming from. And again, to repeat and to really drill down, the more you help them solve their life's problems, the more likely they are to show up for you in these interventions. So engage, 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 really jump in. And if you're having trouble at the organizational level, I'm willing to bet that this next piece sort of deals with that. So here's a parting shot. A dramatic shift, I think, has occurred in black communities nationally, and the black LGBT community has not been left out of that. So what we have to understand is there's a shift more toward individual and community empowerment, and we have to feed into that. Unfortunately, so many ASOs and CBOs have missed that entirely by continuing to operate in this vacuum, isolated to and insulated from or just dealing with the world of HIV. That old paradigm emphasizes reliance on systems that have not always served our communities very well. If you stay in that place, you are really off trend. You're going to be left behind. Your agency and organization will be left behind. To have a meaningful impact in the future, you've got to learn to empower the communities that you serve. Specifically, what that looks like here is that after Project IM ended, we had an opportunity as a community to say, well, there's no more funding coming through this city, specifically for black MSM in general and in a large way. What do we as a community want to do? And so we started a new organization called Blackout. We're doing a community needs assessment, which the survey is almost done, and we're working with the Institutional Review Board at one of the local research universities here at the University of Missouri, Kansas City. And then the other thing that we did was we went back to my organization, the Kansas City Care Clinic, that had sponsored Project IM and got the CDC grant, and said, here are a few things that we need from you, because you guys have been getting from us for several years what you needed to meet your grant deliverables. We need for your office space. We need this, we need that, we need this, and guess what? We got everything. And the value to the clinic is that they have a relationship with us so that when we have this new data, because we have an MOU, a memorandum of understanding with them, we will share that data with them, and we can partner on future grant opportunities. I think there was a question. What type of collaborators and partners can help promote changing the paradigm? Did I have that right, Fran?
Yes, that's right. That's right, Rashaan.
I think the collaborators and partners that can help change the paradigm, again, I think are the outliers in your communities, but I also think they're the individuals who have the most influence in your communities right now. For me, those are people who may not be at your agencies. And so that means you're going to have to get outside of the four walls and lose the mentality of, if we build it, they will come. They probably won't come, and you're going to have to get them engaged in the building of it. So what I mean by that is, it may take time, because all relationships do, but everything big starts out small, and so we really can't just not do that work. It is going to be work, but when you start building relationships with those key influencers and they realize that you are sincere and that you want to change the paradigm for everybody and the impact on the community for everybody, they will join you. I will assure you, and I've seen that not just in my community, but in others that I take this message to as well.
Great answer. Thank you.
So I just want to give a few acknowledgments to Tanisha and to Kristen and to Fran, the team. You guys have been so awesome to work with. I hope that I have addressed as many questions or concerns that you guys have as possible. I hope that it's been substantive. Feel free to reach out to me if you have other questions. But with that, I'm Rashaan Gilmore, and thank you so much for this opportunity to share with you guys today.
Rashaan, that was amazing. Thank you so much.
Tanisha.
Yeah, thank you. I learned a great deal. Just changing the incentive structure, so powerful. So thank you so much for providing such great information. We do have a few questions now, and there are two from Wendell Glenn. The first one is, how can grantees work with SAMHSA to engage and empower MSM from a social responsibility perspective? And this is largely to help enable this really vulnerable population to take some ownership in problem solving and developing interventions to decrease at-risk behaviors. So how do grantees work with SAMHSA to really do that?
That's an excellent question. I think there are two ways to approach this. If you have a specific idea about how you want to do that, obviously you got to start with your program officer and have those conversations. But the other thing that I think is important too is if you have any evidence of what you're doing working, if you see an uptick of engagement with the community because you're trying that approach, and if that allows you then to go back to your program officer and say, hey, we're seeing that the community is really engaging around X approach, we need a little bit more room to explore this further, that can be a really useful way of doing that. And quite frankly, that is how I approached my program officer, Judith, at SAMHSA when I had to make some changes to one of the interventions. And I was a little bit nervous that she'd tell me no, but Judith is a champ, and she believed in us and allowed us to have that room. But it was because I took a little bit of early evidence to her and said, hey, the community is really engaging. I think if we can do some more of this, we'll get more. And that's exactly what happens. And the other thing I would suggest too, Wendell, is to look at what other communities are doing and use that as evidence, even if it's not something you've done yourself. And say, hey, here's what they're doing. I bet that would work here too.
That's great, and that's a great proactive approach with the GPO, and just to be such a great liaison is really inspiring, and I think so important to be the community's voice. So thank you for that. And then we have another question, and it's from Wendell, and he says, through 5 years of outreach with this population, there's a large number who feel that they receive more services, attention, security, and love from the current status of disease, infections, substance misuse, sex work, and other at-risk activities. So they're getting more attention and services, or being rewarded for certain behaviors as opposed to more health positive behaviors. We as providers have to develop a sense of awareness to be able to address this issue effectively, just a process observation of this systematic issue. So does that make sense to you, Rashaan?
I didn't quite get it because my audio cut out a little bit, but.
Okay, I think the question or the statement is more around folks receiving more attention, love, incentives, etc., for behaviors that aren't really in the direction of good health. So disease, infection, they get security and services and love. Substance misuse, there's services there for that. Sex work, there's services there, and for other at-risk behaviors, there's a reward. Not reward, but there's a lot of care embedded around communities engaging in high-risk activities and behaviors. And so,
I'm glad that came up.
Yeah.
I'm sorry, Tanisha. Glad that came up because I think that one of the things that has happened is that we have sort of problematized Black MSM in particular. And one of the ways that's happened is because we have sort of, I think to Wendell's point, rewarded or addressed or celebrated to some extent rewards around the more negative behaviors and engagement rather than coming from a strengths perspective to address how we empower these communities. And to the extent that I've had any success at all, Wendell, I will tell you it is because not only have I been an advocate for my community, but it is also because I have gauged my community from a position of strength. One of the things that happens when our community is not visible is that we tend to feel like there's no place of acceptance or there's no role for acceptance with us. And so consequently, we stay off in the shadows. What that means is providers are often, or program folk are often looking at what are the negatives that we have to address to deal with this. And I just think that's a really negative approach. So I always say it this way. If you're going to persuade your organization to make a change in their mentality and in their approach, you had better bring the community with you. And so everything I'm doing right now is because I've got the community engaged behind me. And I wouldn't say it's quite, the word definitely is leverage, but we basically said that if you want us engaged in your program, here's how you have to deal with us. And I often tell people, look, I'm no Martin Luther King. I don't just wave my hands and all the Black gay folk come swarming after me. But I will tell you that I've earned a reputation and influence that allows me to speak on behalf of my community. That trust is there. And so that has meant that my organization and others others, frankly, within the community have had to listen in a different way and to approach us and to deal with us from a positive space and not just a negative one. We are not HIV. We are not these disparities. We are not these other determinants. We are individuals. We are human beings. We are men and women who want to live our lives. And if you're there to help us, let us tell you how to do that. Sorry, I got a little preachy there.
No, that's great. A strength-based approach is the best way, and it's definitely the direction that we need to go in. Community buy-in is so important. Thank you, Wendell. I got that. Excellent. Thank you. Any other questions? Comments? We'll wait for a little while.
And ask away, folks, on any aspect of this, what we're doing now, what we did before, anything I didn't address, or if you want some more information or clarification on, or anything unrelated that you think might be helpful.
I noted, Rashaan, I love the spirit of competition that you all inspired in your community to really get, folks up and moving. And so, and I think you said it's a continual process, so you do it annually. And I was just wondering if you have used that in a different way with a different program, or if you're thinking about using that kind of model moving forward. I think Tanisha is so great to work with because often she is reading my mind before I even get into it, and I was almost not going to mention this, but here's an idea, and maybe some of us from across the country, if any of you think this might work for you, let's team up and let's be accountability partners and work on it together as best we can. But one of the approaches that I'm really interested to take around some of this is, again, and maybe this is something that addresses Wendell's question too. One of the things I want to do is begin a subscription testing model. And I haven't figured this all the way out yet, but I'm going to get there. I'm a serial entrepreneur. That's who and what I am. So I'm always trying to think of innovative approaches. I think we lost video, but I'll keep talking. The audio was there last time. So one of the things I'm looking at is maybe the reward for folks is not so much that they get an incentive each time that they test, but if at the end of a year or some other designated period, a quarter, they maintain their HIV negative status, there is some reward. Maybe there's some sort of a lottery that they win. And so all of a sudden we're retraining their thought processes, and each time they have a sexual encounter, they are empowered to think about, hey, I've got something that is more or as important to me at the end of this, because again, as I said, if the carrot is big enough, the stick don't matter. So maybe I'm going to choose differently in terms of my risk reduction, or maybe I'll use a condom or what have you. And so that way I'm going to make sure I maintain my negative status so I'm rewarded in X way at the end. And part of the subscription model is that we would approach them every quarter and provide them testing outside of our four walls, wherever it's convenient and comfortable for them, and begin to look at it in that way. That's a more empowering approach in my mind. Fantastic.
Great. Thank you. I do want to let you know we do still have audio, even though for whatever reason the video is blinking. So I would say we certainly have time for your closing remarks, but we're probably not going to be able to do anything else that's visible on the screen with the weird disconnection happening. Sorry for the inconvenience.
No problem. Thank you, Kristen. This has been great.
Timothy's question. Timothy, Gwen, did we get to answer Timothy's question?
We did. We answered that earlier on. And
okay, just wanted to be sure.
No, thank you. Thank you for that reminder. So if there are no further questions, we've got about 2 more minutes, and I wanted to just thank Rashaan again. Rashaan, did you want to say anything before we close?
Just, guys, we can do it. We're in this work because we believe in what we're doing, and if you don't believe that, then you shouldn't be there, but I know all of you believe in what we're doing. It's tough work, but it's so worth it, and there's a lot of support, and feel free to reach out if there's any way I can help.
Thank you so much. You are an awesome resource, and I definitely know and see more and more why Judith loves you the way that she does. So,
I do love Judith too.
So please feel free to contact your GPO around technical assistance. This is absolutely free. What Rashaan did is a snippet of what he can do. There are opportunities for him to actually come out to your organization and help you one-on-one so you can get a really tailored approach to your TA and move forward with implementing your interventions in the way that works best for your community. And we've worked with an organization that really benefited from Rashaan's hands-on approach, and so we encourage you to please reach out to your GPO if you want to know more about how to best implement your EBIs or DEBIs in your community setting. And there are other potential any other potential TA needs that you have, we're here as well. Self-care is really important, and we see it a lot, and we have offerings for that to get individualized services for that. Evidence-based interventions, like Rashaan just talked about. Recruitment, retention, and follow-up, always a challenge and also a strength for many to keep that going, that process going of recruitment, retention, and follow-up. Trauma-informed approaches, motivational interviewing, and so much more. So, and anything else that you can think that you may need a little bit of support with, we have it. It's free, so please take advantage of this opportunity. And also, this webinar it has granted you all an opportunity to get one CEU credit. So that information, the information around that will come out in the email that you will get following this webinar. So thank you very much, everyone. Kristen, is there anything that I might have missed that you want to add?
I think that's it. I do just want to remind people that if you wanted to get the slides, they are up on the screen. It's right below where the video cameras were before. It's a box labeled files, and it's actually called Today's Slides. So if you want to download today's slides, just, right below Rashaan. So if you want to download today's slides, just click on the slide name and then hit the download files button, and that's just going to pop it open in a new window for you, and then you can save it from there. So thank you all again. Rashaan, thank you. That was just such a great presentation. Really enjoyed that. And if anyone is interested in TA, please do contact your GPO. This concludes the audio presentation. We will leave the room open for just a couple minutes in case you need time to grab those slides. And we will send you an email in the next day or so with a link to the recording of this event and also with a link to the information to get your continuing education credit. Thanks again, everyone, and have a great afternoon. Bye now.